Hi there, my name is Farha Peerani, and I'm an assistant professor of medicine at the University of Alberta Hospital in the Division of Gastroenterology. I have a special interest in inflammatory bowel disease, and in today's session, I will be discussing the topic of inflammatory bowel disease in the elderly. Well, the first question we need to ask is, how do you define elderly? Is it over age 55, over age 60, 65? Well, truly, I think there's no great answer to that question. However, the majority of studies that have looked at this question have used the cutoffs of 60 or even 65. Chronological age, though, is not always the best way to gauge how patients with IBD will do. And I will talk about the concept of frailty further on in this presentation. Now, how common do we diagnose IBD in the older patient population? Literature in the past has shown us that there tends to be a bimodal distribution of when IBD is diagnosed. The first peak occurs typically around age 20, and the second peak will occur typically around age 60. And 10 to 15% of IBD patients will present after age 60. The global population is becoming older, and we know this. And that holds true as well for IBD patient population. So if you look at the IBD patients across the globe now, roughly 10 to 30% of them will be over age 60. There was also a recent Canadian study done looking at this question of IBD in our senior population. And what they reported was that 1 in 160 individuals, not IBD patients, but 1 in 160 individuals in the general population over age 65 has IBD in Canada. That's approaching 1% of the population. That is a significant portion of the population that we will have to manage in the future, or even you as patients may have to deal with as a chronic illness. There's also a distinction that I think is very important to make, and that's the distinction between older patients with IBD who were diagnosed in their younger years and now are aging with their IBD, as well as those patients who are truly diagnosed and become symptomatic in their older years, say at age 60. And the two groups likely have different sort of reasons for their disease, and perhaps even different management options could be catered to the two separate groups. Unfortunately, the majority of the literature or the manuscripts that have been published to date don't always distinguish between these two groups. To be completely honest, we don't have a good sense of what causes IBD in the elderly. However, today I want to focus on three concepts that perhaps provide some speculation as to what may be causing this disease process in older patients. The first aspect is dealing with vasculature or blood flow to the colon. Now, as we age and patients get older, the blood vessels in the body become slightly compromised. There's an older study with small patient numbers that looked at blood flow distribution in the colon and how that may perhaps predict the extent of inflammation in the bowel. Second is that there is a higher proportion of ex-smokers in elderly onset ulcerative colitis patients compared to adult onset ulcerative colitis patients. And lastly, statins, which lower cholesterol in the body and affect the blood vessels, they have a protective effect on new onset ulcerative colitis. The second concept I want to focus on is the microbiome, and I'm sure you've heard of how the microbiome is implicated in inflammatory bowel disease, and I would expect no less for it to be implicated in the older patient population. And as patients age, we may see a variation in microbiome composition. So certain bacteria, such as Bacteroides, Firmicutes, Lactobacilli, etc., may increase in abundance, whereas other protective bacteria, such as Bifidobacteria, may decrease. We know that microbiome can be affected by many things. Smoking, diet are some of the factors that can play a role. And the last concept I wanted to briefly touch on is the concept of immunosenescence. As individuals age, the immune system remodels. And this remodeling of the immune system, termed immunosenescence, has been implicated in disease processes such as cancer, as well as in inflammation. And so this process where various, parts of the body are affected, such as the bone marrow, the thymus gland, various blood cells, such as T cells and B cells, become affected. And their typical or usual response to stimuli in the body can be aberrant or abnormal and subsequently trigger an inflammatory cascade. Lastly, in terms of what causes IBD in the elderly, it is thought that younger onset patients have more of a contribution from genetics, whereas the older patients who have an onset of IBD in their 60s or 70s will have a greater contribution from environmental stress or triggers. Overall, the symptoms are fairly similar to what adults or children present with, and those symptoms include diarrhea, include weight loss, can include rectal bleeding, abdominal pain. One symptom that's somewhat paradoxical in nature is the symptom of constipation, and it's not uncommon for older patients with IBD to actually present with a little constipation instead of diarrhea. Now, what other diagnoses need to be considered in the elderly patient who is presenting with symptoms that could be suggestive of IBD? Well, many things need to be considered that we typically wouldn't consider in the younger patient population. And those things include colon cancer, ischemic colitis, drug-induced colitis, microscopic colitis, radiation-associated colitis, and even a colitis associated with diverticulosis or outpouchings of the colon. The answer is not that straightforward. Overall, it would seem that they tend to have a milder form of disease. However, there's evidence to suggest the contrary as well. There was a recent systematic review that looked at the available studies of older IBD patients. And when they looked at the Crohn's patient population, the majority of those patients had inflammation that affected their colon, and the majority of these patients did not have complications such as narrowings or strictures and fistulas. When they looked at the ulcerative colitis patient population in this systematic review, the majority of patients had inflammation involving the left side of their colon. However, the proportion of patients that had that disease extend upwards to involve a greater portion of their colon was roughly the same as you would expect in adults. Now, in terms of the use of biologic therapy or anti-TNF therapy, such as infliximab or Remicade or adalimumab or Humira, the use of these therapies were less in older UC and Crohn's disease patients compared to the younger patient population. Now, it's unclear if that's because, again, do they have less severe disease, or are practitioners more cautious in using biologics in the older patient population? And lastly, in this systematic review, they looked at the need for surgery after 5 years. And actually what they found is that the need for surgery in both Crohn's disease patients and ulcerative colitis patients was actually similar to that of the adult onset IBD patients. Again, putting into question, is the disease truly milder? Now, what I do want to stress as well is that it's important to understand that older patients with IBD can vary in terms of how their trajectory is depending on where they live. So for example, there was a large French study looking at older older onset Crohn's disease patients. And in this patient population, they found that the majority of them, again, 78%, had inflammatory Crohn's. So very few had strictures, very few had fistulas. And over time, as they followed them, only 10% converted to a more complicated phenotype. This is very different than what you would expect from pediatric onset or even adult onset Crohn's disease patients. Now, on the contrary, if you look at a cohort of ulcerative colitis patients followed in Hong Kong, and when they compared the elderly onset ulcerative colitis patients to the non-elderly onset ulcerative colitis patients, what they found is that a greater proportion of elderly onset ulcerative colitis patients actually had their disease extend to involve more of the colon than the non-elderly onset ulcerative colitis patients, suggesting perhaps that the elderly onset ulcerative colitis patients in Hong Kong had a more aggressive disease course. So overall, there is a suggestion in population-based studies that the disease course might be milder in the older patient population. However, the answer is not 100% clear. There are several vaccinations that older patients should be up to date on. Those include Haemophilus, meningococcus, hepatitis A, hepatitis B, tetanus, diphtheria, pertussis, as well as measles, mumps, rubella. However, there are 4 that I want to focus on in today's session. The first one is the influenza vaccination. It's important to note, though, that overall I tend to recommend the influenza injection rather than the nasal administration, as the nasal administration contains a live virus, and patients with inflammatory bowel disease whose immune systems are suppressed, whether it be due to steroids, methotrexate, azathioprine, or even biologic therapy or small molecule therapy such as tofacitinib or Xeljanz, live vaccines are not recommended while patients are taking those therapies. So therefore, the injection would be preferred. Number 2 is the COVID vaccine. The COVID vaccine is extremely important, and as older patients with IBD and older patients who are immunocompromised, it is even more important that this patient population is vaccinated, not only receiving the recommended 2 doses, but as well the additional recommended booster shot, which right now should be administered roughly 14 to 18 weeks after the second COVID vaccine has been received. Number 3, pneumococcal vaccination. Pneumococcal vaccination is administered via Prevnar 13, which is the conjugate vaccine, and then 8 weeks later, the 23-valent pneumococcal polysaccharide vaccine is given, and this is repeated in 5 years to ensure ongoing protection. And lastly, would be vaccination against shingles. One is called Zostavax, the other is called Shingrix. Zostavax is a live vaccine, whereas Shingrix is an inactivated form of the herpes zoster virus. And so therefore, due to the issues with patients not being able to be vaccinated with a live vaccine such as Zostavax while on immunosuppression, the preference is often for Shingrix. Now, even when you compare the efficacy, Shingrix is far more efficacious than Zostavax. So Shingrix efficacy rates up in the 97% range for those between ages 50 to 69. When you compare that to the efficacy of Zostavax, which ranges between 64 and 70%, it's no surprise that Shingrix is the preferred vaccine method, if possible. And another point I do want to raise is that shingles is more prevalent, I would say, in the inflammatory bowel disease population. And age also adds an additional risk factor for shingles to occur. Therapies over and above that can also increase the risk of shingles further. So for example, tofacitinib or Xeljanz, which is a small molecule therapy currently approved for ulcerative colitis treatment, the risk of getting shingles on that treatment for people who are on the higher dose of 10 milligrams twice a day is for every roughly 20 patients treated, one can get shingles. And those that are on the lower dose of 5 milligrams twice daily, for every roughly 100 patients that are treated, one can get shingles. Therefore, I strongly urge you as a patient or as a practitioner to recommend the shingles vaccine for our patients. With respect to efficacy, we do not have much direct data on that question. A lot of older IBD patients have been excluded from clinical trials, and the data that we have looking at real-world efficacy of therapies in older IBD patients are mostly based on retrospective reviews of charts. Therefore, I will spend the majority of my time talking about the safety of the various therapies available for us to treat IBD. Number one, prednisone. Now, prednisone can have many side effects, and this is important, especially when we're talking about the older patient population, which may have underlying comorbidities that are exacerbated by steroid use. We know that there are comorbidities such as hypertension, diabetes, glaucoma, cataracts, osteoporosis, even depression and anxiety that can be worsened by steroid use. So how can we get around that? Sometimes we can, and other times we can consider using another type of steroid called Entrecort or Cortiment in ulcerative colitis patients. This steroid is known as budesonide, and budesonide actually gets metabolized in the liver quite readily, so that only 10 to 15% gets released into the rest of the generalized body. And therefore, the side effect profile is often kinder with Entrecort than it is with prednisone. The second medication is aminosalicylates. Now, data has shown that over 2/3 of older IBD patient population, they are on aminosalicylates. And it's probably because aminosalicylates are fairly benign, they don't suppress the immune system, the oral pills are fairly well tolerable. However, in terms of safety, there are a couple things we should be mindful of, or even just practicality of use. The first thing is that the administration of rectal aminosalicylate therapy or 5-ASA therapy can be hampered in older patient population. It can be harder to retain for them due to compromised sphincter tone, as well as harder to self-administer. Number two is that there's a rare risk of interstitial nephritis or inflammation of the kidneys, and in a patient population who may have already issues with their kidneys or chronic kidney disease, this may be something to be mindful of. And lastly, aminosalicylate use can augment the therapeutic efficacy of azathioprine or Imuran, and therefore we need to be mindful of that. The next therapy is azathioprine or Imuran. And from a safety perspective, there are several things we should be mindful of. One is non-melanoma skin cancer, and so these include things like basal cell carcinoma and squamous cell carcinoma. And studies have shown that the risks of non-melanoma skin cancer do increase with age. And in spite of patients stopping taking azathioprine, that risk persists. Now, on the contrary, the lymphoma risk also increases with age. However, if patients stop taking azathioprine, then the lymphoma risk returns to the baseline population risk. Overall, if you want to give an overarching number for what is the risk of lymphoma in a patient on azathioprine over age 50, it's probably somewhere around 1 in 350. And as they age up into their 80s, it can even approach 1 in 200. Lastly, the use of azathioprine or Imuran can decrease the anticoagulation properties of warfarin. Now, often older patients can be on warfarin to prevent strokes, and this obviously has important clinical implications for the older patient population. All in all, I typically restrict my use of azathioprine in the older patient population, and if I am to continue using the therapy, it has to be after I've had an explicit discussion with the patient regarding the risks and benefits. The fourth medication we can talk about is methotrexate. Very briefly, methotrexate use in the older IBD patient population needs to take into consideration if the patients have pre-existing liver disease and or renal or kidney impairment. Now, why don't we talk about biologic therapies? The majority of evidence revolves around anti-TNF therapy. This includes therapies such as infliximab or Remicade, adalimumab or Humira, and golimumab or Simponi. And these therapies, when we decide to use in the older patient population, we need to be mindful of one comorbidity in particular, and that is congestive heart failure. A study has shown that a high dose of infliximab actually caused worsening heart failure in patients, and therefore, in the older patient population who has concerns with heart failure, we need to be cautious in that patient population. Also, along the lines of anti-TNF therapy, we look at the safety of the therapy, both from a real-world perspective and a clinical trial perspective. First, with respect to the real-world evidence, there's some older studies looking at Italian data, and this was prospectively collected data in patients over age 65 on biologic. And it showed in that report that patients were at an increased risk of infection, increased risk of mortality, and even increased risk of neoplasm or cancer in this patient population. However, we also have data that looked at randomized controlled clinical trial data from the trials looking at infliximab or Remicade and golimumab or Simponi. And in that publication, what they showed actually was that there was a baseline elevation in adverse events in the older patient population, but there was no incremental risk in adverse events due to the anti-TNF therapy itself. So here we're again getting slightly conflicting stories. However, overall, I would say that the majority of the literature would suggest that the risk of infection on anti-TNF therapy is slightly higher in the older patient population. Now, with respect to the medications, vedolizumab or Entyvio and ustekinumab or Stelara, again, very limited data speaking to the safety in the older patient population. Overall, from what we know in terms of the mechanism of action and extrapolating from in ustekinumab from other disease entities and in vedolizumab from some of the smaller sort of retrospective studies that have been done, these biologics appear to be safe in the older patient population. And lastly, we can talk about tofacitinib or Xeljanz. And the one concern that came about within the last year relates to the risk of thrombosis or blood clot, more specifically pulmonary embolism or a clot in the lung. There was a registry looking at rheumatoid arthritis patients over age 50 with at least one risk factor for heart disease, and what they found that there was a slight signal suggesting that those in the higher dose, 10 milligram twice a day of tofacitinib or Xeljanz, were more likely to suffer from a lung clot or even death. Now, when we look at the IBD literature, just in all comers, not just older patients per se, but in all comers, we don't see necessarily a similar risk. However, that is something for us to be cautious about. There have been studies looking at this question, and one study looking at a large database of patients confirmed that yes, older patients do have increased risk of postoperative mortality, increased risk of postoperative complications, increased length of hospital stay, increased risk of needing a blood transfusion, increasing chance of cardiac, renal, neurological complications, and for the ulcerative colitis patients, an increased risk of infection, and for the older Crohn's patients, an increased risk of a blood clot. And so surgery is not taken lightly in the older patient population. Nevertheless, what I do want to stress is that if surgery is required, a timely referral to a surgeon is required. And once again, it's not only age or chronological age that matters, but it is really the concept of frailty. Well, there's no gold standard to define frailty. There are two main conceptual models, one being the physical or phenotypic model of frailty. And in that model, there are 5 characteristics that are looked at: fatigue, low activity, weakness measured by hand grip strength, weight loss, and slow gait. And if a patient demonstrates at least 3 of those 5 characteristics, then they're considered to be frail. The other model is the accumulation of deficits model. And this model is based off of patients' comorbidities and illnesses. And again, various scores have been created to look at the accumulation of deficit model of frailty. Now, within the inflammatory bowel disease sphere, frailty has been shown to better predict outcomes compared to age, and these outcomes include mortality, hospital readmission, need for surgery, infection. Frailty is an all-encompassing term, and there are many, many aspects to frailty, and those include psychosocial well-being, nutritional status, cognition, social support, patients' comorbidities, as well as functional status. And in the IBD patient population, the concept of frailty is only recently being explored and is going to be an important factor to take into account not only when we are treating our older patients with IBD, but IBD patients across the age spectrum. From this session today, I hope you understand better that the prevalence of elderly IBD is increasing, that the natural history or how patients with IBD in their older ages fare can vary, that we need to be proactive about vaccination, that we should be cautious with the use of azathioprine or Imuran in those over age 50, that we should refer those who need surgery in a timely manner, and then appreciate that we shouldn't be purely concerned with chronological age. Really, the concept of fit versus frail needs to come into the discussion. Thank you for listening.